7 o'clock, ma'am. Shall I start?
Just wait a few minutes more. Not many have joined. 2 minutes more will wait.
Okay, ma'am.
Sanchi, it's being live streamed, so I will first introduce and then we can start.
Okay, ma'am.
Shall we start? I'll just introduce. Good evening, all. We start the second class of this year in FNCC group. Today, Sanchi is going to present a case on management of severe head injury and how do we protocolized manner manage this patient. Jaya ma'am is the moderator. Let's start, Sanchi.
Yes. Good evening, all and one. Today I will be starting with the management of severe traumatic brain injury. This is a following class from the last class in which we have discussed the trials and management in the mild to moderate traumatic brain injury. Uh, Today, myself being the presenter, Dr. Sanchi, my moderator is Dr. Jaya ma'am from Medanta, Gurgaon. So let us begin with the case history. So there's this Mrs. RK, who is a 46-year-old female drive resident, a resident of Jhajjar, Haryana. She faced a head-on collision accident when she was driving a four-wheeler vehicle, which got hit by the truck. The patient had severe head injuries and facial injuries, for which she was initially taken to some local hospital, but due to lack of the tertiary care facilities, she was brought to Medanta for further management. So the past medical history of the patient, she had history of hypertension since 10 years on regular medication, no any seizure disorder, thyroid dysfunction, asthma, TB, no any drug or food allergies, and medical history, she was on telmisartan 40 and tablet amlong 10 mg since 10 years for hypertension. Past family history, no any significant history, and social, no any history of smoking, alcohol or drug abuse history, normal sleep wake habits. On continuing with the general physical examination for the patient, she was height 150 centimeter, weight was 60 kgs, BMI is 23, the pulse was 94, BP was 139 by 86 millimeters of mercury. She had a significant pallor and no cyanosis, clubbing, icterus, edema, lymphadenopathy, and no facial puffiness at present. The airway examination, no visible deformities, no neck mass, mouth opening was three finger breadths, MMP grade 3, large tongue. The patient got intubated in the ER in view of falling GCS. When she had come to the Medanta ER, she had a GCS score of E1, V2, M5, which stands for a score of 8. Patient received to the neuro ICU being intubated. The CNS examination, the GCS was E1, VT, M5. She was intubated, maintaining on pressure control, volume guaranteed mode of ventilation. The patient was restless, had a motor response of flexion to pain, that is M5. On a motor system examination, bulk of muscles was normal and bilaterally equal in both upper and lower limbs, normal and bilateral tone in both upper and lower limbs, and power was 3 by 5 in all over 4 limbs. Cardiovascular system was normal in examination. Auscultation heart rate of 90 per minute. First and second heart sounds were audible. Respiratory system was more or less normal. The upper respiratory tract was normal. Thoracic examination, the respiratory rate was 16 per minute and thoraco-abdominal type of breathing. No tracheal deviation, bilateral equal movement with respiration, no visible swelling, no wheeze or stridor. So palpation was normal, percussion bilateral coarse creps were heard, and auscultation normal vesicular breath sounds heard. So, per abdominal examination was normal. Auscultation, bowel sounds were heard. So, further, right from the ER itself,
One
the
second,
laboratory.
Sanchi.
Yes, ma'am.
Sanchi, hold on.
Yes,
So,
ma'am.
elaborating on your history and general examination, from the
Yes, ma'am.
history point of view, do you want to add something more with respect to the facial injury? What else would you, if someone was presenting to you,
Yes,
what
ma'am.
other factors would you want to know because the patient has facial injury?
Yes, ma'am.
What would
Uh,
you want to know?
Ma'am, in terms of facial injuries, if there are any severe facial injuries which can also lead to oral and nasal trauma, and due to this preceding oral and nasal trauma, there could be a risk of difficult airway, and because she had a lot of bleeding, also she can have a risk of increased risk of aspiration, also, ma'am.
Yeah, that is one thing. The
Yes, ma'am.
second thing, uh, a- along with if she can bleed, what else can leak through the nose?
For bleeding,
You said one complication would be bleeding.
yes,
You
ma'am.
wanted to see if there was any bleeding. If blood
Yes,
can
ma'am.
come through the nose, what else can come through the nose?
Ma'am, CSF can also leak from the
Yes.
nose.
So you have to also ask the history of rhinorrhea. How
Rhinorrhea.
does that change your, uh, if you were to receive a patient with CSF rhinorrhea or profuse nasal bleed, what will you immediately worry about?
Ma'am, whenever there is a CSF rhinorrhea, there could be anterior cranial fossa fracture also in the patient. And since there is a ACF fracture, she can immediately have she can immediately undergo in less ICP, the because of loss of
Chances of
CSF.
meningitis increases.
Meningitis, increased risk
And
of meningitis because of breakage.
what will you not insert?
Ma'am, the Riles tube will not be inserted in such a kind
Yes.
of patient. Yes, ma'am.
Yes. So immediately when you come, you have to ask these two questions because the nurses will go about inserting the NG tube, which has to
Yes,
be
ma'am.
avoided with clinical. Yeah, please go ahead. Thank
Okay. So, in the ER itself, certain laboratory investigations were sent. Since the patient had also had bleeding, so the hemoglobin was low. That is 7.2 gram per deciliter, for which one PRBC was transfused in the ER itself. The WBC count was 5,200. Platelet count was 1.5 lakhs. The blood urea nitrogen was 10, and the serum creat was 1.2. Going to the further investigations, the liver function tests were more or less in the normal range. The sodium was 136, potassium 3.7, and chloride was 105. Rest bicarb was 24, and calcium was 9.1. The CT trauma protocol. So it is a routine protocol that takes place in the cases of severe traumatic brain injury. That a CT trauma protocol is done in our institute, in which the brain, the spine, the abdomen, and the peripheral bones are seen. And the CT trauma protocol in the head and neck, the brain had multiple contusions in the right and left frontal regions of around. So this contusion volume was taken by ABC upon 2 formula, in which it was around 20 to 22 ml total hemorrhagic volume. No midline shift or herniation was noted. Shall I continue further?
Yes, please.
Okay. The facial bones, in the CT trauma protocol, the facial bones, the patient has a fracture of the left zygomatic bone, fracture of the nasal bone. The cervical spine alignment was preserved, no fracture or canal compromise was there, and vascular, no dissection or occlusion. Though there was alignment was preserved for the cervical spine, the patient had been in the Philadelphia collar for cervical spine stability. And in the chest, the lungs were clear, no contusions or pneumothorax, mediastinum, no hematoma or vascular injury, ribs or sternum was intact, abdomen and pelvis was intact, solid organs, there was no laceration or hematoma, hollow viscera was no perforation or free air was observed, and vessels, no active extravasation, and pelvis was intact. And spine, the alignment was preserved for thoracic and lumbar spine, no fracture, extremities, left humerus, fracture of shaft of humerus, other soft tissues, no large hematoma, and foreign bodies are not detected. So the final CT trauma protocol impression was right and left frontal lobe contusion. That is, by frontal contusions were observed. Fracture of left zygomatic bone, fracture of nasal bone, fracture shaft of left humerus, and no additional acute traumatic injury detected elsewhere. So, summary being Mrs. RK, 46-year-old female, resident of Jhajjar, Haryana, faced a head on collision accident while she was driving a four wheeler which got hit by truck in case of is a case of severe traumatic brain injury with bifrontal contusions and polytrauma. She was received in ER for which she got intubated in view of GCS of 8. Shall I continue further, ma'am?
Please.
Okay. The treatment initially, the patient was intubated. She was received on PCV volume guaranteed mode due to hemodynamic instability, fluid resuscitation, and inotrop support in terms of infusion noradrenaline was started. All routine investigations were sent. Patient was offered surgical management but refused due to lack of finances. So, patient was further continued on conservative management. So, this was
Why
the
did
drug
you
chart.
choose volume control mode?
Yes, ma'am.
Why did you choose volume control mode ventilation?
Ma'am, initially when she was taken on pressure control volume guaranteed mode so as to give a proper volume to the patient and maintain the respiration for the patient. She was not very much responsive to be on the CPAP mode of ventilation, ma'am.
Okay, all right, continue.
Okay. So, surgical management was given, but relatives refused due to lack of finances. Patient was continued on conservative management. Further, this was the drug chart in which the patient was started on infusion fentanyl of 1 to 2 micrograms per kg per hour. IV infusion was given in continuous mode. Mannitol was started for the patient. 0.5 gram per kg IV bolus was given every 8 hourly, and levetiracetam 1 gram IV levera was given, followed by 500 gram IV, 500 mg IV, sorry, mg, it should be 500 mg IV BD dose. Noradrenaline was started in IV infusion in continuous form so as to maintain the BP for the patient. Pantop 40 mg was given for the patient, and enoxaparin 40 mg subcut was given for the patient, and cabimol, that is injection paracetamol, was given 1 gram IV every fourth hourly so as to have fever control, and injection ceftriaxone 2 gram IV was started for the patient for infection prophylaxis.
Now,
So,
Sanchi, two things here.
yes, ma'am.
Did you have a better choice of anti-edema measure in this
Yes, ma'am.
scenario?
3% hypertonic saline could have been started for the patient also. But the
Why
initially
was
it was a
mannitol?
neurosurgical decision to start mannitol, ma'am.
And do you agree with the antibiotic prophylaxis?
Ma'am, initially it is a standard protocol that we start with ceftriaxone, ma'am.
Prophylaxis for what?
Ma'am, for infection.
Every severe head injury doesn't get infection. Why do you need a prophylaxis?
Ma'am, the patient could have also aspirated, so that's why we give a standard protocol of
Was there any
ceftriaxone.
evidence of aspiration? Why would you give prophylaxis for aspiration?
Um, no, ma'am.
Only indication, that also is a relative indication, is if you have CSF rhinorrhea,
Okay,
then
ma'am.
you may give a prophylactic antibiotic cover for
Yes.
prevention of meningitis. But that is also not a guideline. It is
Okay,
a
ma'am.
very eminence-based practice. It's not actually a guideline. And in
But
that
day in
case,
and day out, we start with injection monosef 1 gram IV BD or
these are the
Supasif shall be
controversies.
given for the patient. Yes, ma'am.
Correct. These are the controversies. There's not much evidence for that. And do
Okay.
you think it is preventing?
No, ma'am. No,
Is there a
regardless of the antibiotics, there is some sort of infection the patient gets in eventual
yeah?
days.
So even in the VAP prevention guidelines, if you see the bundle, there is no prophylactic antibiotic.
Yes, ma'am.
What is SDD? Since you brought it up, what is SDD?
No, ma'am, I'm not aware. STD.
Selective digestive decontamination. That
Okay.
revolves
Okay.
around the same thing. You give prophylactic antibiotic in centers where you have a very high incidence of aspiration and VAP to reduce your VAP incidence.
Okay, ma'am.
That's the only area where you give prophylaxis for preventing VAP. Again, the choice, there's no much evidence about it. And those are only kind of propagated in centers where you have very high incidences, not in everywhere.
Okay,
So
ma'am.
ceftriaxone was probably an overkill. Yeah, please carry on.
Okay. So, in the eventual days, because of the bifrontal contusions, the patient also had increase in the size of the edema. The edema increased on subsequent scan for the patient, in which the GCS further deteriorated, and she went down to E1 VT M1. She was not responsive at all, and the pupils were also 5 mm bilaterally dilated. So it was a decision that the patient was started on 3% hypertonic saline, in which a bolus 2 ml per kg IV was given over 10 to 20 minutes, and the infusion of 3% HTS was started on 1 ml per kg per hour IV. So, because of the increased cerebral edema, which caused further deterioration in this case, eventually patient was hemodynamically unstable. She got started on triple inotropic infusion. That is, we had started her on an infusion noradrenaline, vasopressin, and adrenaline also. And due to worsening organ failure, the patient had AKI. And further, in a period of over 2 days, the patient was unable to make further, and the patient was declared. So this was the case, ma'am. So basically, she because of the frontal edema,
One
because
second,
of the
one second,
parietal
one second.
contusions. Yes, ma'am.
So, if you look at the CT scan,
Yes, ma'am.
would you have prognosticated just based on the CT scan that her outcome was going to be very poor at
Yes,
admission?
ma'am. At the initial
What
stage
is in
only,
the
when there was bifrontal contusions was observed for the patient along with edema, that time only we had told the relatives that they have to go for the surgical management, but due to lack of finances, they were not able to go further. So hence, we had already declared a poor outcome for the patient. But on the subsequent day
Sanchi,
only, she had yes, ma'am.
if I say we shouldn't even offer surgical management, the patient is going to have such a poor prognosis that even surgical management should be deferred. If I
Okay,
say
ma'am.
so, based on CT scan, am I justified? Anyone can answer, fellows, anyone can answer. What is peculiar about that CT scan that you should be saying, okay, this is very poor prognosis? What is your idea about that bifrontal? What is the usual time frame that bifrontal is going to cause herniation and emergency surgery?
Ma'am, within a matter of time of 6 to 8 hours, the patient can herniate, and
Suppose the
she can
usual
deteriorate.
time frame, suppose
Yes,
it
ma'am.
is not this bad, and you have a patient who is around 8 to 9 by 15 and is in your HDU with bifrontal contusion. What is a good time frame to send him to the ward or discharge him home for a bifrontal?
Oh, ma'am, bifrontal, we have to be very watchful. Even if
Why?
the patient is in a HDU,
Why?
uh, sudden deterioration occurs in such cases, ma'am, in bifrontal.
Delayed. Because it is bifrontal, the subfalcine herniation will happen only when one side gets really swollen up and herniates. Otherwise, both will kind of equalize each other, and there is no unilateral worsening. So it
Okay,
takes
ma'am.
time. The usual time frame of 48 to 72 hours of watchful monitoring, and then you say, okay, all right, unlikely to have any more worsening. That doesn't stand good for bifrontal. But my
Okay.
first question still remains, what is peculiar about this scan? There are lots of past and present fellows. Who wants to answer? You'll get 5 extra points in the exam if you answer this. What is white cerebellar sign? Kanchi.
Yes, ma'am. White cerebellar sign. Ah,
Recently someone had put, I think Dr. Ishipura had put, Nestle had put one CT and asked what is this sign? So the ischemia and the edema has caused so much of hypoperfusion in the cut that you have put that everything else is looking black and only the cerebellum is looking white.
okay, ma'am.
So this is a sign that raised ICP is going to cause almost a cerebrocirculatory arrest.
Okay,
The
ma'am.
supratentorial segment is completely ischemic, and it's only the infratentorial segment which has some circulation which will soon go. So
Okay.
in this point, with this scan, probably even surgery will not help.
Yes, ma'am.
Okay, so that's why I asked you in the first thing, if I don't offer surgery, am I wrong? Continue.
No, ma'am. It's okay.
Continue, please.
Okay. So, as we had discussed that she already went into cerebrocirculatory arrest in a matter of 2 days, where the patient had worsening organ failure, AKA, and in within 2 days she was declared. So, shall I continue further?
Please, please.
Okay. So initial assessment and resuscitation. So I shall discuss our protocol in airway. Whenever there is a GCS of less than equal to 8, any kind of airway compromise or hypoxia, we use the rapid sequence induction with cervical spine protection and avoid hypoxia in which PaCO2 should be greater than 60 millimeters of mercury and SpO2 should be more than equal to 94. Breathing, avoid routine hyperventilation and goal is for 35 to 40 millimeters of mercury. Short term hyperventilation only for impending herniation. Circulation targets, the systolic blood pressure target was more than equal to 110 millimeters of mercury in 18 to 49 years of patients, and more than 50 years it should be more than equal to 100 by 110. Avoid hypotension at all cost in such kind of patients because any single episode of hypotension will lead to increase in the rates of the mortality. Disability, GCS, pupils and motor scores are continuously being monitored early. Correct contributing factors that if any kind of hypoglycemia, seizures, and hypothermia, prevent hypothermia in such kind of patients, and we maintain a normothermia of 36 to 37.5 degrees Celsius. So, imaging indications for CT, regardless of any moderate or severe traumatic brain injury, even if the GCS is less than 13, we get a CT done. Traumatic brain injury, focal deficit, anticoagulation, seizure or worsening examination, repeat CT, neurological deterioration in cases of neurological deterioration. So, we have a routine protocol to do a repeat CT in 6 hours in neurological deterioration, ICH expansion risk, and after neurosurgical intervention. So indications for ICP monitoring, EVD or intraparenchymal it is monitored, GCS less than equal to 8 or abnormal CT. If the GCS is less than equal to 8 plus normal CT and more than equal to 2 of age more than 40, motor posturing and systolic blood pressure less than 90. Treatment threshold being when the ICP is more than 22, we treat and the cerebral perfusion pressure goal should be 60 to 70.
So,
So,
Sanchi, how will you justify that you didn't put an ICP monitoring here?
yes, ma'am.
How will you justify yourself that you didn't put an ICP monitoring here? You had an abnormal CT, GCS was less than 8.
Yes, ma'am.
So, why didn't you put?
Hmm.
There is one word in this indications for ICP with which you can support yourself.
When the GCS was less than equal to 8 plus abnormal CT,
You should have put.
we should have put.
What is
Should have
what
put.
is very important? Patients should be salvageable. In a
Yes, ma'am.
salvageable patient,
Uh,
ICP should be inserted in these conditions. If it is a non-salvageable patient, you do not. If
Okay,
you
ma'am.
have a bilaterally dilated and fixed pupils, your CT scan was with white cerebellus and impending cerebral circulatory arrest, you are justified in not putting the ICP.
Okay,
Okay,
ma'am.
clinically, even before the CT scan, if someone comes with fixed dilated pupils, again, it is very unlikely that they are going to make it. So it is justified to not put.
Not put EVD.
Provided there is no direct injury to the eye and that is what is causing fixed dilated pupil. Okay,
Okay, ma'am.
all right, continue.
So for the ICP management, there is a tiered management for the ICP management in which the tier 1 stands for head and elevation of 30 degrees, neutral neck position for the patient. Sedation or analgesia started in terms with fentanyl infusion or propofol infusion. We control the fever for the patient. If the patient is having uncontrollable fever episodes, then the blood cultures are being sent and routinely we use in injection Cabimol, that is paracetamol 1 gram with ibugesic and Dynapar round the clock, and ventilation. PaCO2 is managed with 35 to 40, and normovolemia is maintained for the patient, and we avoid any sorts of hyponatremia. So the tier 2 management is hypomannitol versus hypotonic boluses, controlled ventilation with mild hyperventilation for short periods with PAC out of 30 to 35, incisive drainage via external ventricular drain. So
So,
tier 3, yes,
Sanchi,
yes
this
ma'am.
tiered approach is coming from which guideline?
And this is the BTF guidelines, the Brain Trauma Foundation guidelines.
There is there is CBIC guideline which also talks about tiered approach, and then what it mentions is about the anti-edema measures. So 3% saline, continuous versus bolus, which is more effective.
Ma'am, wait a minute. Shall I?
You have the CBIC guidelines later.
Yes, ma'am.
Are you presenting CBIC guidelines later?
No, no, ma'am. No, no, no.
Uh,
I shall continue. Sorry. Actually, I had a call. Sorry. So the tier 2 guidelines in which
so my
sorry, ma'am,
question
I've
is
lost on the question. It was the Brain Trauma Foundation guidelines and
CBIC guidelines, and in the CBIC guidelines there is a mention how to administer the 3% saline. Do you give it directly as continuous infusion or do you give it as boluses, which is preferred?
ma'am, first we give a bolus dose, and then we give the continuous saline infusion, continuous 3% HTS for the patient.
What does the guideline say? How should you give? Why?
Um,
So it is the civic guideline says the boluses are more beneficial than giving continuous
Continuous
infusion.
infusion. Okay,
The
ma'am.
physiology behind that is when you give a bolus of 100 ml of 3%, there is such a difference in the osmotic pressure that there is a sudden drop and ICP drops because of that. The side effect of it is that provided the patient's heart is good, because this can cause a severe overload.
Okay,
This
ma'am. Okay.
can lead to pulmonary edema if you are having a LVH or your borderline cardiac condition. Make sure that that is not there. In that case, to bring an immediate reduction in ICP, boluses are better than infusion.
Okay, ma'am.
Continue.
For boluses are more important rather than continuous infusion.
More useful, yes.
Okay. So in the tier 2 management, the optimized hemodynamics, we optimize hemodynamics with the help of vasopressors to maintain a cerebral perfusion pressure of 60 to 70 millimeters of mercury and neuromuscular blockade, though it is not routinely practiced in our institute, but the neuromuscular blockade with the help of infusion vecuronium or cisatricurium, it is given to reduce the metabolic demand and prevent coughing or straining in patients. And advanced sedation, barbiturates, that is thiopenton, for burst suppression in cases of EEG. Tier 3 protocol is again neuromuscular blockade, controlled hyperventilation in which 30 to 35 PCO2 is maintained for the patients, and barbiturate coma in which the ICP is more than 22 in refractory and hemodynamically stable patients. And deep compressive craniectomy is done for refractory ICP. So surgical indications. So in cases of epidural hematoma, even if there is a 30 ml EDH, it is a protocol to evacuate. And in smaller with neurodeficits and mass effect, we evacuate the hematomas. And in cases of STH, when the thickness is more than 10 millimeter or midline shift of more than 5 millimeter, we evacuate. And any STH which causes the neurodeterioration, we evacuate. So, now in this, our case had a bifrontal contusion. So it was more than 20, it was around 20 to 22 millimeter. So it was not with midline shift, but Jesus decline was seen. And in such cases with contusions and any mass effect, we immediately evacuate. And in cases of depressed skull fracture, when there is a depressed fracture more than skull thickness with contaminated wounds, we elevate and debride the materials. So further, homeostasis and coagulopathy, we reverse the anticoagulation, warfarin, PCC plus vitamin K, prothrombin complex concentrate plus vitamin K for dual oral anticoagulants, specific antidotes that we have discussed earlier. We give idarucizumab and nexanet alpha if available, and if platelets and vasopressin is given for antiplatelets, and the tranexamic acid. So this was discussed in the CRASH 3 trial. Within 3 hours, especially in the mild to moderate traumatic brain injury, the tranexamic acid is much more beneficial. Shall I continue further?
Yes, yes.
Okay. In cases of seizure prophylaxis, it was mentioned in the Brain Trauma Foundation guidelines that the early seizure prophylaxis within the first 7 days, Levera 1 gram IV, that is every 12 hourly, or phenytoin loading plus maintenance dose, and no prophylaxis was given for late epilepsy for more than 7 days. And supportive ICU care being nutrition, since it was also mentioned that as soon as within 5 days or 7 days, it should be started. That is, early parenteral nutrition also helps with reducing the risk of the ventilator associated pneumonia in such patients. And DVT prophylaxis mechanical, that is sequential compression devices are given in our institute for the patient, and pharmacologically when bleeding risk is acceptable. And GI prophylaxis, so in our institute we do have a routine protocol in which injection pant of 40 mg is given for the patient once a day, and repeat CT is done at 6 to 12 hours in cases of clinical deterioration. And further, yes ma'am.
Continue, please.
Okay. Family counseling is also being done. So there is a multimodal approach where the neurosurgical, neurologic, and the ICU team have counseling processes with the family in which the prognosis of the patient is being discussed with them, and what all the therapies that can be given to the patient are discussed with the family. So, let us discuss about the role of mannitol in traumatic brain injury. So, mannitol, it is an osmotic diuretic used in traumatic brain injury to reduce the ICP by drawing water out of the brain tissue into the bloodstream. So, it is a first-line hyperosmolar therapy for acute ICP crisis, but should be used carefully because it can cause hypotension, renal dysfunction, and rebound ICP elevation. So mechanism being, so it reduces the blood viscosity, improving the cerebral blood flow and oxygen delivery to the tissues. It has a rapid onset of action within 30 to 60 minutes, and it has a clinical role in TBI. Indications being acute ICP elevation when it is more than 20 to 22, herniation syndrome, so fixed or dilated pupil with Cushing's triad, and also as a bridge for definitive therapy. So, till the time the patient goes to the surgery, the mannitol is started for the patient, and IV administration of 0.25 to 1 gram per kg. 0.25 to 1 gram per kg is the dose that is being given via central or peripheral lines. And with the mannitol, it is also important that we maintain the serum osmolarity also. We continuously monitor serum osmolarity to be less than 320, and the renal function if there is any kind of AKI that is seen in the patient. Monitoring strict fluid balance, avoid hypotension, and serial electrolyte and osmolality checks are important. So risk being because excessive diuresis happens in such kind of patient and already the patients are hypovolemic. Further, it can lead to reduction in the mean arterial pressure and which can also compromise the cerebral perfusion pressure since we have a target to maintain the CPP of 60 to 70. Renal dysfunction can lead to AKI, electrolyte disturbances and hypotension, renal failure and severe dehydration. So let us go with the debate of mannitol versus 3% saline. So why over 3% saline? So it is 3% saline.
Sanchi,
Yes, ma'am.
Sanchi, rather than this, do you have anything about ICP monitoring?
Uh, ma'am, further like slides.
Yeah.
Okay. Key consideration.
Okay, start with TBI trials.
Okay.
This mannitol and 3%, I think everybody knows we have only 20 minutes left.
Okay,
Do
ma'am.
this more.
Okay, ma'am. So, further, the TBI trials that have been discussed. So, there are four trials that have been discussed for the crash. So, crash trials of 1 to 4 are landmark international studies which are done for the traumatic brain injury. So, the crash one, it was a kind of pilot study in which more than 10,000 patients of head injury were studied, in which high dose corticosteroids, that is methylprednisolone, was given for the patient. Uh, and increased mortality in the steroid group. Impact corticosteroids are contraindicated in acute traumatic brain injury management. So, in Crash 1, it was discussed that the methylprednisolone was given, but it already increased the mortality in the steroid group. Crash 2 trial, it was for the tranexamic acid, in which was given in the 8 hours of injury. Around 20,000 patients were studied, and tranexamic acid became the standard of care in trauma resuscitation worldwide. And Crash 3, around 12,700 patients were studied. IV tranexamic acid was given within 3 hours of injury, and findings were reduced head injury related death in patients with mild to moderate traumatic brain injury, and no clear benefit was seen. It was recommended in mild to moderate TBI if given early. So, Crash 4, it is an ongoing trial done in 2024 with mild traumatic brain injury, in which intramuscular tranexamic acid was given. Findings were reduced risk of microbleeds, potential to lower risk of dementia progression, and safety profile was acceptable and could expand tranexamic acid used to mild traumatic brain injury in older adults. So the DECRA trial, we can see that in 155 patient, it was studied that with severe diffuse traumatic brain injury and ICP, more than 20 millimeters of mercury for more than 15 minutes, early bifrontal decompressive versus continued medical management. So it was studied that decompressive reduced the ICP and shortened the ICU stay, but there was no mortality benefit. Worst functional outcomes were observed at 6 months of age, and early prophylactic decompressive, it is not beneficial and may worsen the outcomes. So similarly, the rescue ICP trial, which was done for the patient. So 400 patients were studied with severe traumatic brain injury in which ICP was more than 25 millimeters of mercury, and for 1 to 2 hours maximal, and along with that barbiturates were given. So decompressive versus continued medical management, there was a reduced mortality. More survivors were there with vegetative state or severe disability. So it was concluded that late rescue decompressive saves lives but increases survival with disability and long term rehabilitation in patients. So the best trip trial was also done, in which ICP versus management based on clinical examination was studied. So no difference in mortality or functional outcomes. So it challenged that ICP monitoring alone improves outcome, rather than but now it is done that multimodal and individualized management is much more helpful rather than just ICP monitoring.
What
So
is the
polar
biggest
trial,
drawback of the best trip?
yes, ma'am.
What is said about best trip? Why did this result come up that ICP monitoring did not improve the outcome? Where was this carried out?
Ma'am, in Bolivia.
Why was it carried out in Bolivia? Who was the primary author? Where did he belong from?
No, I'm not aware, ma'am.
Primary author is an American,
Okay, ma'am.
and because it was not ethically acceptable in America, it was done in Bolivia, a country where routinely ICP monitoring was not done.
Okay,
So the
ma'am.
biggest comment or biggest drawback accused about this trial is that the results were not interpreted properly. That's
Okay,
why
ma'am.
I asked you about ICP. What is important when you're monitoring ICP? What all do you look at when you're monitoring an ICP? Say you have an intraventricular catheter, the gold standard.
Yes.
How do you go about targeting your tiers of therapy based on the ICP?
Okay, ma'am. So basically, we have three tiered measurement in
No.
which
How will you decide which tier to go on based on the ICP?
so ma'am, based on the ICP, so it is our recommended. So we in our institute we basically may have a ICP of management till 22 millimeters, and
So
based on that.
I see on the monitor a
Mhm.
number of 16, but
60.
my waveforms have plateaued. It's not
Yes,
the
ma'am.
sinusoidal waveform with the notches and all. My waveform is flattened, and my ICP number is 18. Should I treat? Not.
So in such cases, ma'am,
So this is actually what happened in Best Trip trial.
yes,
ICP
ma'am.
is not the number alone. As the
Okay, ma'am.
compliance of the brain reduces, not necessarily the number will hit the target for intervention. The
Okay, ma'am.
waveform will change.
Okay, ma'am.
Okay.
But
So
ma'am,
if
the
you have a
waveforms
confusion,
could be like any kind of respiratory fluctuations or ischemia. The
no. So you
waves can
have to
also
know
be changed.
what pattern it is. If the
Okay.
P2 is higher than P1, the compliance is
Lost.
lost.
Yes, ma'am.
The example I said is a plateau wave.
Yes, ma'am. Yes, ma'am.
Plateau wave will, it has to, you don't wait for the numbers to change. You see plateau wave recurring and staying there for some time. That is a bad prognosis, even worse than a number hitting of 22.
Yes, ma'am. When
These, these
it
parameters,
has a thing that it can lead to reduced brain compliance and potential pressure.
correct. So when you have someone who is not very competent to understand these things with the ICP monitoring, these smaller things will be lost.
Okay, ma'am.
That is what is the comment about the best trip trial, that the numbers were seen and not properly treated, and that's why this trial failed.
Okay, ma'am.
Understood? Yeah,
Okay, ma'am.
continue.
Okay. So basically, because of the waveform, so in any kind of when P2 is greater than P1, that means it has a reduced brain compliance in ICP monitoring, ma'am.
Sure, go ahead. Go ahead with your next slide.
Yes, ma'am. So in polar trial, so it was done. So basically, the hypothermia was studied in patients of the traumatic brain injury, in which a multi-center randomized control trial of 511 patients with severe blunt traumatic brain injury was studied with GCS less than 9. So early prophylactic hypothermia versus normothermia was studied, but there was no improvement in favorable outcomes at 6 months. Mortality at 6 months was more or less similar of 21%, and hypothermia associated with more complications, that is pneumonia. So routine prophylactic hypothermia is not recommended. And
What
HOPES
was
trial was
wrong in
done.
this trial? What was
Yes,
wrong
ma'am.
in this polar trial? The design of this trial,
Ma'am, it was a multi-center randomized control trial
timing?
for around 6 months, ma'am.
No, no, no. It's an early prophylactic treatment. So what
Yes, ma'am.
happened was the hypothermia was induced in the ambulance,
Yes,
and
ma'am.
anyone with a GCS of less than 8. So what happened when they started to analyze the results? Most of the low 5 and 6 GCS patients were drunk, were alcoholics drunk, and they started inducing hypothermia. The side effects were skyrocketing, and they would anyway wake up and agitate. So they
Okay.
had to be taken off. This was early, was not the answer to the question whether hypothermia really helps a severe TBI patient, because
Okay.
many had to be taken off because they were very soon done and they woke up. It was not a true severe head injury. Understood?
Okay, ma'am.
There was a recruitment fault in the study design.
Okay, ma'am.
Continue.
So further, HOPES trial was done for rehabilitation and psychosocial support in patients with acquired brain injury, and it showed that rehabilitation and hope-centered investigations are important after acute ICU care. So further there were boost trials which were also conducted in such kind of patients with traumatic brain injury, in which the brain tissue oxygen monitoring was done to standard ICP guided care improves the outcome in severe traumatic brain injury patients. So there was this pilot study of Boost 1 trial in which severe traumatic brain injury patients were studied. It was a kind of pilot study in which ICP monitoring alone versus ICP plus PbTO2 monitoring was done, that is brain tissue oxygen monitoring was done, and demonstrated feasibility of multimodal monitoring, and it also needed larger trials. So Boost 2
So,
was also
why
a
was the
similar
pilot study
trial.
undertaken,
Yes, ma'am.
Sanchi? Why was the pilot study undertaken?
Ma'am, so as to study the smaller population in such patients.
Why? 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 If you see most of the studies, there'll be a phase one, which is a feasibility trial.
Yes, ma'am. Just like
Okay.
attached trial, there was also pilot study
Everything
trial
is,
and
yes, correct.
yes, ma'am.
So in that, the algorithm that you want to apply, will it is it possible in real scenario to be applied? That is the question they are answering. After that, how many, does it cause harm or not is another phase. The first one is only for feasibility. Listen, let's say
Okay,
there's a
ma'am.
pilot study. Then comes the actual study, the 2 and 3 phases.
Yes, ma'am.
Continue.
Okay. So the Boost 2 trial was a randomized control trial in which it was seen ICP only was done and versus ICP plus brain tissue oxygenation was studied, and which showed that significant reduction in hypoxia episode in the brain tissue oxygenation group. It was showed that the trend was improved neurological outcomes but not powered for mortality or functional outcome endpoints. So it supported to moving to phase 3, and similarly ICP only strategy versus ICP plus brain tissue oxygen monitoring strategy was seen. Clinician adjusted fluid, ventilator settings, transfusions, and medication to maintain both ICP and oxygen targets. So endpoint was functionality outcome at 6 months, that is Glasgow Outcome Scale, GOSE, and the secondary was to study the mortality, any kind of outcome complications, and duration of monitoring. So impact was could it establish whether multiple modeling improves the survival as compared to ICP alone. So track TBI trial was also studied in patients. So last time we had discussed that in terms of mild traumatic brain injury, there are also blood biomarkers that are being studied. So track TBI, it is the transforming research and clinical knowledge in traumatic brain injury patients. It is a large multi-center US trial. So it was to see the precision medicine refined trial design and identify the predictor recovery, and the key contributions were to see the biomarkers, that is the glial fibrillary acid protein, the UCHL1 for FDA approved, and advanced MRI detects the subtle injuries which were missed by CT, highlighting that even mild traumatic brain injury can cause lasting disability. So this is the summary that we have seen. In CRASH, it was studied in 2004 for moderate to severe TBI, which showed that the steroids does not have much effect. Crash true for Tranexa. Crash 2 and 3 were for tranexamic acid. That is tranexamic acid which is given. So reduces
Sanchi, there is
bleeding
a
death.
fault. Sanchi, there is a fault in the track TBI. Track TBI is not the name of the trial. Track TBI is a consortium of multi-center trauma groups, and they have a unified reporting system, and the data is stored centrally, which is used for several studies.
Okay.
Track TBI data is used for many of the studies. It's not a trial by itself.
Okay.
Continue.
Okay. Further, so this is the summary of the trial. The crash was for first one was for the steroids. It showed that there was increased mortality with steroids. So steroids, that is high dose methylprednisolone, was more or less not much beneficial in patients. Crash 2 was for Tronexa. It reduces the bleeding deaths if given within 3 hours. And crash 3 was done in 2019, where tranexamic acid was used, and it reduced the injury related deaths in mild to moderate traumatic brain injury. Next, the let's us discuss the DECRA and the rescue ICP. In DECRA trial 2001, early decompressive was done, and it showed that lower ICP, though the patient had lower ICP in DECRA trial group, but they had worse functional outcomes with early surgery. And in rescue ICP, so in rescue ICP, it was seen in 2016, in which the population had severe TBI plus refractory ICP. When the decompressive was done, there was a comparator was the maximal medical therapy. But at 6 months, it was seen that the craniectomy reduced the mortality but increased severe disability in overall mole survivals. So last were the best strip trial in severe traumatic brain injury, ICP guided therapy, clinical plus the comparator being the clinical plus imaging guided therapy. There was no difference. That is, the TBI can be managed without routine ICP monitoring in resource limited settings also. And polar trial in 2018 for normothermia. So it was the intervention was early prophylactic versus normothermia. No improvement was seen, and hypothermia was not recommended in TBI patients. And in HOPE's trial, it was done in the severe traumatic brain injury, the intervention being therapeutic hypothermia and versus normothermia. The neurological outcome was studied, but no benefit was observed. So, more or less, the polar and the HOPE's trial told us that the prophylactic hypothermia as well as the therapeutic hypothermia both are not beneficial in TBI patients. So next being the boost to trials, as we have discussed early, and there's also the Synapse ICU trial, which was done in year 2021 for moderate to severe traumatic brain injury, in which ICP monitoring was seen, and 6 month neurological observation was done, in which it was seen that ICP monitoring associated with lower ICU mortality rate, but no ICT was performed. So hence, ICP monitoring is more or less beneficial only in ICUs. Thank you, ma'am. So all of my trials have been discussed, ma'am.
So, Sanchi, from what you presented about the trials, two things. What is your take on decompressive craniectomy in your setting, and about the ICP monitoring in your setting? You are working in a low middle income country. Based on these two completely contrasting methodology of the trial, and both giving you negative answers, in your setup, how will you apply?
Ma'am, even in our setup, more or less, whenever the early decompressive craniectomy is being done for the patients, we could not see. Uh, we could not see very much great benefit in patients because more or less there was functional disability which was observed in the patients. Uh, there no, even if the early decompressive was not much beneficial. So this was our takeaway, ma'am.
So today, suppose tomorrow a patient comes to you on a Friday night
Yes, ma'am.
and with midline shift of 8 mm,
Hmm.
one pupil non-reacting, and on the weekend the neurosurgeon is not available. What are you going to offer them?
Um,
GCS when he came was M5, total score of 7 by 50.
Total score of 7, ma'am.
Hmm. Motor score was 5.
5. Ma'am, maybe I should do a negative comparison for the patient because if the patient is already having a poor GCS and a poor outcome, then the surgery might not be
You didn't
beneficial for
ask
the
me the
patient.
CT, I didn't tell you the CT. CT only shows a right subdural hematoma.
OTP. Oh, sorry, ma'am.
CT shows only a right subdural hematoma.
Right
This
subdural
is,
hematoma.
yeah. So this is the problem with both the studies. One was very early and the
Okay.
other was too late. Rescue ICP was almost, most of the patients were taken almost 48 hours later. You have tried all medical management, including paralysis, only then you offered surgery. The other one was too early, I think 6 hours if I'm not mistaken. So for LMICs, you lie in the middle. You hardly get a patient so early to the ED, and at the same time, you can't be sitting for 48 hours deferring the life-saving decompressive craniectomy. So we will
Okay.
have to, both this doesn't apply to us written in stone that you have to follow this. We have
Okay.
to adapt to our setting. Another big problem with both the trials is they looked at functional outcome at 6 months. And there is more and more literature saying functional recovery keeps occurring up to 2 years. At six
Okay,
months,
ma'am.
you saw a GOSE of 4. At the end of first year, he could be 8. He could be functional, completely independent and working, useful to the society.
Yes, ma'am.
The assessment at 6 months was probably too premature.
Okay, ma'am.
So very soon, these these trials will have to be redesigned and redone.
Okay, ma'am.
And I think there is a proposal for all of that. But in the meantime, in our setup, everybody will have to take case to case depending upon our situation. Like the one I said, neurosurgeon is not going to be available on Saturday, Sunday, on Friday night. Someone comes with possibility of a good outcome, possibility of life saving. You will have to take that.
Yes, ma'am.
Can't say his functional outcome 6 months later is going to be we don't know what. I'm not
Hmm.
offering surgery. It's not possible. So we
Okay.
might have to go for a decompression way early than what the evidence says. Similarly, temperature. The polar was too soon and hope was too late. If you
Yes,
see
ma'am.
all the guidelines, temperature cooling measures are given some grade 2B, 3 evidence. It is not completely ruled out
Yes,
because
ma'am.
if properly applied, it still shows benefit. So
Okay,
there
ma'am.
again, we don't have the last word about it.
But
Yeah,
ma'am, in
ma'am,
our
you will.
institute, may keep it in normothermy itself, unless and until the patient is having recurring episodes of fever, in which cannot be controlled by multimodal and paracetamol, ibugesic. Then we go for hypothermia, and other than that, we only prefer normothermia and TBI patients in our case.
Most important is to avoid hypothermia. So fever
Yes,
has
ma'am.
to be avoided at all costs. Inducing hypothermia, everybody has their own practice. If you are able to induce properly, and moreover, do not cause a rapid rise in temperature, everybody has their own experience and their own. They've seen some good cases, they haven't. I have personally in our place we don't have the IV flu. I mean, the machines to induce a targeted temperature, so we don't do it.
Okay.
Yeah, ma'am, you've been
Yeah,
very.
Shalini. Yeah. No, yeah, I just wanted to say in our institution, yeah, the we avoid hyperthermia. So we just go for normothermia, not for hypothermia. For the same reason that increase in temperature will cause a lot of secondary brain injury. So, and another thing, I mean, anybody can answer. If we don't have the facilities for an invasive ICP monitor, can anybody just enumerate the non-invasive monitors we can do at the bedside?
Ma'am, bedside pupillometry that is being done.
What else? First of all, the GCS and the pupils.
Yes, ma'am.
That is done frequently, can be done at the bedside. Anything else?
Uh, TCD monitor, ma'am. TCD monitoring.
TCD, yes. I mean, not available at all centers. Anybody can answer. ONSD, have you done, Sanchi? I think practice is
Optic nerve
almost
sheet
over. Huh.
diameter.
Yeah, yeah.
No, ma'am.
I think we should make you do it. It is our fault that we are not making you do it. These are all, I mean, not direct evidences, but if you don't have invasive monitoring, a lot of places, the surgeons also don't prefer. We can rely on certain non-invasive techniques also.
Okay, ma'am.
Anybody has any questions? Nothing in the chat box. If nobody has any question, we'll wind up. And we thank Sanchi and Jaya ma'am for a wonderful session, well presented and well elaborated on the recent things about severe head injury. Thank you very much. You can convey to your friends we would love your participation. Today there were very few listeners. Usually it goes in numbers of 20s. Today was in single
Yeah.
digits. Let's hope they catch it in the coming weeks. Thank you, Sanchi. Thank you, Jaya ma'am. And thank you
Okay.
to all
Thank
the
you,
listeners.
Shalini. Thank
Thank you so
you.
much, ma'am. Thank you, Shalim, ma'am. Thank you, Jai, ma'am.
Bye. Good night.